the young generations should focus on the biology.
How has this evolution changed your own philosophy?
Vitamin D is something everyone underestimate.
How do you personally decide which material to use in different clinical situations?
A lot of interesting questions you are putting. You can use everything.
Why is maintaining collagen is such an advantage for the results?
Having a faster vessel regeneration means having a faster and better bone regeneration. I cannot do any implant without guided surgery. We are not mechanics. We are physician. I'm not able to answer you.
Welcome to today's episode, where we're going to talk to one of the most interesting areas and fields in dentistry. It's guided bone regeneration. And I would say that our guest today hardly needs an introduction. Professor Luigi Canullo, oral surgeon, researcher, and I would say one of the most respected voices in the field of implantology. Professor Canullo, by the way, has received numerous awards throughout his career, including Best Clinical Presentation, Best Scientific Article, Clinical and Basic Research Prizes, Best Clinical Research. He's an active member of Italian Academy of Osseointegration, also European Academy of Osseointegration. And he serves as a reviewer for leading journals in implant dentistry. And by the way, when I found the information about that you have like more than 100 publications in international journals, I was a little bit crazy because it's such a big impact on this field. But before we start speaking about some clinical stuff and clinical questions, I just would like to ask you to share a little bit what first drew you to the specific field of dentistry as implant dentistry.
Let's say that I started thinking about dentistry just a couple of days before starting the uni, because initially I started thinking about medicine, but I changed my mind because medicine, at least in Italy, means a very huge road before being capable to have a personal life. So I thought that, dentistry would have been a acceptable compromise between the real life and the interesting of the studies. So I started dentistry, and it was, how do you say, love at first sight when I started surgery. And the evolution of surgery is, of course, implant dentistry, and all the fields related included bone regeneration.
So, over your years of practice, expertise, research, how has your personal philosophy toward implant treatment evolved? As you said, lots of innovations, lots of changes.
I really think that the young generations should focus on the biology, and that is my personal advice and my personal lead in my clinics. I always try to understand the biology behind what I usually do in my patients, because unfortunately, I would say we are taught to just follow paradigms which are organized by industries. Very often, we should do think about the patient. We should think about which is the easiest, best, most comfortable option for the patient. That is my inspiring idea.
And usually this requires some understanding of biology. And this is why I found lots of information, lots of your lectures include this word biology. Your research, as I said, often bridges biology and clinical application. Over the last, I would say, 2 decades probably, we have
No,
seen...
unfortunately not.
No?
3 decades.
3 decades. Okay, so it means that for over 3 decades, we have seen a clear shift from mechanical reconstruction, what you have said already, toward biologically driven regeneration. How has this evolution changed your own philosophy? I mean, when you plan the augmentation, when you're doing the guided bone regeneration, especially in terms of respecting this biology you're speaking about, versus forcing architecture.
This is an interesting question. I would say that I would ask for a couple of seconds to explain the term biologic, which you were referring to. It's like a milestone for me. Biologic is a composite word in my idea, made of biology and logic, and that is the inspirational idea I have every day in my clinical practice, in my research field. We must understand the biology and we have to apply our logic to find the perfect or at least the better treatment for the patient. Which means that sometimes if the patient is not in the condition to have the better result because of his personal systemic conditions, what we have to do is to stop, make the patient healthier, and then start our surgery. Yesterday at the meeting we had, I spent a lot of time talking about vitamin D.
Exactly.
Vitamin D is something everyone underestimate. And I've done a study showing clearly showing the direct correlation between the level of vitamin D in the patient and the quality of the regeneration. And there are a lot of studies referring to the importance of vitamin D in the loss of early loss of the implants. So what I'm saying, if the patient is not in the possibility to perform his better regeneration, we have to stop and allow the patient to reach this position. Clinically, when I have a patient with a very low level of vitamin D, I stop the treatment. I ask the patient to refer himself to the physician till his vitamin D level is correct.
Can you elaborate a little bit more on this? Does it mean that each time before the guided bone regeneration, do you require some results of
Yeah.
the vitamin?
I always ask my patients a complete profile of fats and the vitamin D value.
So the fats is also something essential.
Yeah. That's what I really think. So I'm doing my research on that. My feeling, my personal feeling, my clinical feeling is that if the patient has an alterated profile of fats, the bone regeneration is not perfect. What I know for sure, because it's already proven, is that vitamin D is really important.
I can see. Okay, then since we are speaking right now about the predictability, about the results that we're searching for, we have to probably understand that the bone augmentation is still and remains one of the most challenging aspects. In your view, what are the key factors that determine whether augmentation, regeneration, will be predictable and long-lasting?
Another important and massive question. Okay, my personal idea is that we have to analyze the patient both from a systemic point of view. I told you, vitamin D, fat profiles, And from an anatomical point of view, we cannot expect that all the defect can heal at the same level. We cannot expect to treat all the patients the same way, having the same result for all the defects. So what we have to do is to remember that we are physician and we cannot do the same thing for all our patients. So we have to elaborate a specific strategy to exploit all the possibility the defect leave us. And knowing the defect, you can find the correct graft material, the correct amount of autogenous bone, the correct membrane, the correct membrane fixation, and then having a good result.
Does it mean that each of your consultations with your patients includes also consultations with periodontists, with some other practitioners as well?
Of course, my team always supervise the patient, always supervise the patient till the surgery, of course, because the surgery is my responsibility. And what I do always is trying to allow the patient to find the ideal teeth position, ideal periodontal health, in order to allow me to do the best surgery.
Since we're starting talking right now about the periodontists, right? Yesterday you had a wonderful congress, and you have emphasized quite a lot of times the role of soft tissue management in terms of stabilizing, I would say, in successful regeneration to achieve stable soft tissue, sealing over grafted sites. How do you do that? How do you choose the membranes to contribute to better soft tissue management?
A little step back. First of all, I always take a CBCT and an impression of the patient, and I study my patient on my computer. Having clear which kind of defect I have, having clear which kind of surgical treatment I should provide, then I'll try to minimize the aesthetic consequences due to such a surgery. So I try to minimize the modification of the soft tissues. Sometimes when I cannot avoid problems on soft tissues, what I do is using graft, autogenous graft, or very often nowadays heterologius graft.
I can see. But
Yesterday, as you saw yesterday, talking about the meshes, the titanium meshes, I suggested, because I do every day, to use derma
membrane.
materials to exploit the soft tissue healing, avoiding perforation of the membranes or the mesh itself.
I can see, but again, we have seen several cases, I mean, not only in your practice or all over the world, where we face complications like dehiscenses, like graft exposures. So my question is that, are there some early intervention techniques that can prevent this failure of regenerative process? Speaking about bone
Okay.
grafts and soft tissue.
Okay, the best treatment for dehiscence is preventing dehiscence, which means that you have to minimize the vertical incisions, because vertical incisions means less blood supply, and finding the correct design of the flap is a key factor for the success. Then, when you have a dehiscence, which is always possible, of course, what you have to do is to understand what you have below the dehiscence, which means if there is a collagen membrane, whatever, the problem is as an auto resolution, let's say, because this is not a great problem. If below the essence there is a mesh, or there is a cortex membrane, oh, that is an issue. What I strongly recommend is before the surgery, the suturing, inserting PRF, inserting collagen membrane over the meshes in order to have a second chance, a second possibility of soft tissue closure, a derma itself. But at the end, if you have an exposure, my personal suggestion is reopening and remove the membrane or the mesh.
Does it mean that if the membrane stays exposure, we just remove it? No, there is no chance that the healing process will continue successfully.
No, I'm sorry. Maybe I was not clear in my statement. What I said in my experience is that if a not resorbable membrane, a mesh or a Gore-Tex membrane, my suggestion is to remove it. If you have resorbable membrane, for sure the essence will disappear. Below, of course, you will lose something, but it will be not so clinical relevant.
I can see. So I think, as far as I understand, you're a fan of a PRF.
I am, actually I am.
Do you use it in each case?
Not really in each case, but I find that it's a supplement which helps the healing. Needless to say, if you have a bunch of platelets in the essence, in injury.
In the end, PRF is the part of a biology, right?
Yeah, of course it is.
Yes.
Of course it is.
So we're getting back to this
biology. Yeah, that's it.
Interesting. Just a few steps back. Many clinicians struggle when choosing the graft. Should they choose xenograft? Should they choose autogenous, alloplastic grafts? How do you personally decide which material to use in different clinical situations?
A lot of interesting questions you are putting. Thank you.
I prepared.
The choice of the graft, autogenous or heterologius, depends on the healing pattern of the defect. If the healing pattern of the defect is very high, let's say post-extraction site with 4 walls in a young patient, you can use everything. If the healing pattern is low, elderly patient, 3, 2 walls, what you have to do is to boost your graft. And the only way I know for boosting the graft is using autogenous bone. I am a big fan of autogenous bone. I'm a big fan of autogenous bone, mostly in the early stages. I mean, when I have possibility, as much as I can, I do prefer to take some autogenous bone to speed, enhance the quality of the healing.
Well, that's interesting because, sometimes what I can hear from your colleagues is that autogenous bone, it's biology, it's our own bone. It's something that works better in complicated cases, not on the early stage, but on the latest stages. And this is why sometimes they prefer to combine xenograft with autograft. In your cases, you are saying right now that you like
I
to
like to
see the
use
results
autogenous plus
on
heterologous bone,
early stages.
even on the early stage.
I
If
can
the
see.
defect is difficult to heal, if the healing pattern is low, I don't see any reason to avoid a small amount of bone autogenous bone collection.
Yeah, probably it gives a very good boost
Yeah,
in the very early stages in
yeah.
the start. So yeah, the process will be much more successful. Okay, when speaking about choosing is something now this industry is full of the products, full of good brands, and the choices and the range is quite big. So when speaking about choosing, yesterday you got very nice, very good questions about osteobile products, Technos products. We have seen lots of grafts, membranes, blocks, etc. So when you're performing vertical or horizontal augmentation, how do you choose the xenograft? Will it be, I don't know, particles like Genos, or it will be sticky bone like GTO? What are the what is your experience and expertise? How do you choose the products when you're performing horizontal or even vertical augmentation?
If I mix autogenous plus heterologous, of course I'm looking for graft, an heterologous graft, the better heterologous graft on the market, which is an heterologous graft which has collagen, native collagen, and I mix together. So I look for, I would say, particles. If I should use only heterologous bone, such as in a easy post-extraction site or in a sinus lift, I do prefer sticky bone. I do prefer material which can be automatically stabilized. Okay, let's say that.
Uh-huh. I can see.
I cannot use this kind of material because in the vertical regeneration, in the vertical crustal regeneration, because it's a little bit different to mix together with the autogenous bone.
Okay. So, speaking about the bone grafts, what are the most common misconceptions?
The most common misconception to me is that you can use heterologous graft in every occasion. You can use only heterologous graft in every occasion. There are a lot of key opinion leaders showing short time follow-ups with the radiographic presentations. Of course, at time zero, half an hour, half an year after, 1 year after, you can find radiographically good outcomes. I really trust that from an histological point of view, and mostly after a longer period of observation, this kind of graft cannot be, sustainable, cannot be helpful for the patient. I saw so many periimplantitis due to bone regenerations with only graft materials, with only, yes, heterologous bone materials, which allows me to rethink the traditional bone regeneration, to rethink about the traditional bone regeneration.
Just a few minutes ago, you mentioned collagen-based grafts. You mentioned it as it is important. So many clinicians are curious about collagen preservation in grafts. Why is maintaining collagen is such an advantage for the results in terms of biology?
Yeah. I mean, having collagen, of course, is, I mean, scientifically documented, of course, allows for a better and faster vessel reconstruction. And vessel reconstruction is the first step of the healing, even of the bone healing. Having a faster vessel regeneration means having a faster and better bone regeneration. So I'm really sure that this kind of evoluted, let's say that, graft material will be the future of our field. Always thinking that collagen give us a step forward, but does not allow to reach the complete regeneration. It's always a matter of biology. Collagen gives a plus. Let's say that.
Okay. You know, in such tough biological process, even this small plus is very important.
As we discussed yesterday, Usain Bolt is the record man, not because he's the fastest, because he's the fastest. He's the more complete, the most complete runner, the most how do you say. Correct runner. He has the best shoes. He trains a lot. Every step adds something, which at the end is make Usain Bolt the fastest guy all over the world.
Let me ask you one more question. As far as I know, you do have your own practice, right, in Rome. So when a patient he doesn't have a tooth and he wants an implant, the patient's first consultation is with whom? What is the process of the clinic? Okay, he's stepping into your clinic. Yeah.
He steps in my clinics and he has a chat with me. And the first thing I ask him is what does she want? What does she want? What is her ideal achievement? Because as a clinician, we can provide different level of quality. Okay, we saw yesterday. If you want papille, there's a step. If you want bone regeneration, there is a step. If you want something else, there is a step. Every step is time consuming, is effort consuming, is money consuming. So the patient should give me the right indication for what is his own requirement. I don't know if I was enough clear. Okay.
So, and then you suggest the patient like two options. The first one is your vision or how it has to be done. And the second, you're telling your patient that, okay, we can achieve this result with doing this.
Yeah.
But at the same time, we can offer you this one, which will
that's my
better
strategy.
impact, etc., etc.
That is my strategy. I spend a lot of time on this. I spend a lot of time, a lot of energies to show up the patient, visually show up the patient how it could be done. So usually I have a chat with the patient, then I ask the patient to undergo a picture section, a radiographic session, impression session, and then I call him again to show him up how I see the patient and which kind of option we could have to provide what he's looking for.
I see. Let's dive in a little bit into digital dentistry. Since we're speaking right now about first consultations, about entering the clinic, about your approach, What tools in digital implant dentistry do you use even during your first consultation or during the treatment?
No, I use a lot digital dentistry during my second consultation, and because I ask my technicians to prepare a visualization of what the result will be. Okay, so the patient can clearly see himself before and after. I spend a lot of time taking facial scannering, taking tooth impressions, digital tooth impressions. I do a lot of pictures of the patient in order to have all the graphic tools to show up the patient how I see him, how I will see him after the treatment. From a clinical point of view, I've been using digital planning, digital implant planning since I would say 2009, 2010, I would say. Now I cannot do any implant without guided surgery, because guided surgery gives you in advance all the clinical situation of the patient. So you can, as a surgeon, you can preview the intervention. You can preview all the possibility you have. You can foresee the incision. You can foresee the defect. You can understand where the implant should be positioned, which kind of regeneration you might face. A lot of informations that allows you to have a more relaxed surgery.
And it's prosthetically driven, which is
And
absolutely brilliant.
needless to say, sorry for forgetting to say before, of course, all the projects are prosthetically driven. As we discussed yesterday, it's like soccer. You have to know that you have to score in the opposite opponent net, and it's the same for us. You have to know that you have to score, having clear in mind where the tooth will be. My professor used to say that the patient pays you for a tooth, not for an implant.
Exactly, because he's coming to your
Yeah.
clinic to see the aesthetic result. He wants to see the tooth. So yeah, absolutely, absolutely, I do agree. Okay, so we're speaking about implants. In particular, I would like to ask you about the primary stability. Primary stability is often discussed from a mechanical perspective, yet you emphasize the biological component of stability. How do you balance insertion torque, bone compression, and vascular preservation in dense or grafted bone?
This is a very, I would say, interesting topic. And again, this is just biology, nothing else. We were taught that if we have more dense bone, we were lucky, because the traditional implant site preparation is to create an hole, an under prepared hole, and insert a compressive implant. Because let me say, from a biological point of view, we underestimate the importance of the bone. We just compare the bone to a wall. Okay, so what do you do? What would you do if you have to put a pin in a wall? You just use a a screw in a wall, okay? You just prepare a small hole and then you screw into it. And the more torque you use, the happier you are. Because you think, okay, the screw is very stable. Fine at time zero in a wall. If you do it in a bone is completely different from a wall, because behind a wall there is no biology. Behind the bone there is. We have to clearly understand that the corticalized bone is completely different tissue from a medullar bone. Corticalized bone has a very few amount of vessels, very few amounts of cells. So it's stiff. It's like crystal, okay? Very, very resistant to compression, but very fragile, okay? And that's what happens. If you push the bone, the cortical bone, what you would have is a fantastic resistance. But if you laterally compress the bone, and you are a physics, so you can perfectly understand what cut forces means. What you will have is a fracture, exactly what you would have doing this procedure on a crystal, on a glass. Okay, if you do a small hole in a glass and then you insert a conical screw or whatever, the mismatching between the hole and the screw will create a lot of cracks all around the glass. What's the clinical result of this kind of treatment on a cortical bone? Crack means resorption, period. Biologically, period, let me say. But we were taught to get our primary stability on the cortical bone. We should avoid the cortical bone stability. How can we reach the primary stability? In the medullary area. That's the answer. Why? Because the medullary area is like a sponge, it's more elastic, it's plenty of vessels, plenty of cells. So you can under prepare the site, and there you can achieve the primary stability. So I did several studies on this topic, clearly showing that if you overcompress the cortical area, you will have bone resorption. No discussion. No discussion. And I prepared a so-called funnel hybrid technique to achieve the primary stability. Basically, just to show you up how it works, you have to zero decompression of the cortical area. So you have to prepare the cortical area having zero mismatching with the implant collar. Below, where you can easily see the medullar bone, you can overcompress the bone, and there you can achieve the primary stability. Talking about that, of course, this means that you need a proper device for inserting the implant, which show you up not only the, I will say, the torque, the insert torque highest value, but you need to control the curve moment by moment. And there are very few tools able to give you this kind of diagram. That's what I strongly recommend every colleague to use. Try to think about that. We were taught that 120 200 of what was it called, of torque insertion would be perfect. This is, to me, a nightmare for the bone. I prefer to wait 1 month more instead of having a very fast loading, because if fast loading means over torquing the bone, it means that you will lose that bone. Maybe in 1 year, maybe in 2 years, but you will lose it. No discussion on it. And that's what biologic really means. Review what you are taught to do, trying to understand the real biology behind what you do, and trying to use your logic to achieve the better result, the better road to the better result.
Does your recommendation apply to grafted areas as well, even on cortical?
Yesterday we talked a lot about how the grafted area could be considered young bone. Young bone means that it's a fragile bone. Regenerated bone is very fragile, so we should use all the tools we have to minimize the trauma on the young bone. Small flaps, bioactive implants, better preparation, better implant site preparations.
Better planning.
Better
the
planning,
end.
of course, better planning.
Speaking about trauma and torque, I have one more question to you. Let's imagine the case when we have a D1 bone type, and you have already placed an implant. You're trying to place an implant, but it's stuck. And you're trying to do your best, and you see that the torque is already 70 Newton centimeters. What should you do? Should you leave it at this high torque, or you should wait a little bit?
What I do is to use all the tools I have not to overcome 45 newtons. Why do I use this threshold? Because in my studies, I saw that you don't need more torque to achieve implant stability. 45 is really far away from the minimum. And at the same time, you preserve the connection. When you insert an implant, you stress not only the bone, but also the implant connection itself, because the implant is mostly made of titanium 4 degree, which is very biocompatible, but is not so strong to resist an over stress, an over mechanical stress. The implant tool, the implant insertion tool, is made of titanium 5. So, as a physics, please tell me where the distortion will be
More.
visible.
In the first one. Yeah.
Yeah, of course,
Yes.
because the material is more flexible. Let's say
Exactly.
that.
Softer.
Yes. And if you will have an implant perfectly placed, but with a connection not perfect, what will be the consequence? Connection instability, which means in the short, medium time, infection of the connection, infection of the periimplant sulcus, and probably in the medium time periimplantitis.
I can see.
That is biology. That is the way I intend my profession. We are not mechanics. We are physician. We manage living tissues. We manage materials in the long term. We have to guarantee our patient a long-term result. Thus is the connection instability very clearly a very clinically relevant problem? No, but is 0 point something to the world record.
Luigi, unfortunately, you have a flight like in 2 hours. We have to sum up our discussion. So I'd like to ask you probably the last two questions. There is a ongoing debate about cortical versus cancellous regeneration quality after augmentation. So based on your historic experience, how relevant is this distinction in predicting implant survival or marginal bone loss?
Oh, please say it again.
Look, there is an ongoing debate about cortical and cancellous regeneration. Speaking about the quality after augmentation. So
You mean the graft material?
exactly in
Okay.
predicting implant survival or predicting marginal bone loss.
I'm not able to answer you. I usually answer question I personally tested before. I do not have any study on this. Honestly, I don't think that this is relevant because I can see that a cancellous bone could be easily resorbed, but we are talking about 1 year, 2 years. Does it really affect the stability of an implant in the long term? I doubt it. But I cannot clearly see if what I say is truth or is a lie.
And the last question. We know, everyone knows that the dentistry is one of the most stressful professions. How do you handle the stress? What is your hobby?
This is a very good question. I am a pragmatic man, old man, and the first thing I do is to prevent stresses in my office. So I try to have only funny people around me, only funny and effective people all around me. I try to treat only patient I like, which is a good advice for the for the podcast listener. I try not to work till midnight. Sometimes I can do it, and I try to do the job I love the way I love, and then I go home where I have my kids and my wife. I love watching movies, and early in the morning I go swimming because I need the stressful activities. And on Sunday I do very huge walk all around the room, trying to relax my mind. And on Sunday afternoon I go to the stadium supporting my football loved team. That is the way I live.
That's
Okay.
great. I liked the way you said, I'm trying to prevent the stress. Again, even nowadays in our usual life, we have to plan everything and prevent everything from the stress. Thank you, dear professor. It was very interesting.
It was a pleasure to me. Okay.
Thank you.
Thank you.